testicular interest in back surge. So I thought I'd just have a chat to you about something that we see relatively often, and it's sort of quite a good thing to pick up because it's a bad thing to miss, really. So we just do our usual little vignette. So you're an intern, you finished a shift at ED, pretty happy with how you've been doing suturing a patient's hand. You send him home and then you decide to pick up the next patient with your diligence. And it says, Mr. DG is a 60-year-old man who's been complaining of sudden onset leg pain. He's been brought into hospital by his wife. Now, what are you thinking as you sort of walk into his cubicle? I'll start with ones I know names of. Joel!
What are the cardinal features of his pain?
Okay, good. So he tells you it's sort of a burning pain along my left leg. Yeah.
Okay, how long ago did it start?
Yeah, so it came on sort of pretty suddenly about 4 hours ago, but I've been watching the footage, so I didn't bother to come in. But the pain started to get a bit worse.
Okay, all right. So it's been getting worse over that time?
Yeah.
Okay, has he ever had this pain before?
No.
Okay, and he was just sitting down when it happened?
Yeah, just sitting down on the couch.
Okay, so he's, okay, right. Is he a generally sedentary man?
I wouldn't say so. I think I'm pretty active.
Okay, all right. And has there any periods of prolonged stasis recently or inactivity?
No.
Okay.
Not that I can think of. What do you mean?
Long flights, sitting in a movie theatre, sitting watching the footy for 4 hours.
I do watch the footy quite a bit, and I'm a truck driver, but other than that.
Okay, all right. Okay. Also want to ask about his past medical history.
Yeah, sure. Pretty fit, otherwise I think I've got something called diabetes.
Okay.
But other than that, I'm just on a tablet, and I'm pretty sure everything's good.
On a tablet for the diabetes?
Yeah, just a tablet for diabetes.
Okay, all right. Cool.
Jump to the next so you can see. So basically, exactly what you're saying, burning, throbbing pain along the left leg. Another thing you might want to ask is if he's weak in that leg. So he's noticed that, after he got up from the couch, it does feel a little bit weaker than it did before. Never felt the painful like you asked, sudden onset like you asked as well. He's tried some sort of analgesia, so a good way of gauging again how much pain he's in, just some Panadol, NSAIDs, whatever he's got at home. Doesn't really do anything. No sort of preceding symptoms prior to this. History otherwise, so like I said, past medical history, so diabetes, HbA1c is sitting around 10. Smoker, current, 40 pack years, drinks 2 to 3 beers a week. Just metformin, nothing else that he's aware of. Okay. That's where we're sort of at. Now, what are we thinking at this point? Nad, next one along.
Okay. So, I haven't, okay, not done the exam. So differentials, I sort of think about it in terms of an anatomic approach. Sure. To unilateral, we've established unilateral leg pain.
Yeah.
Okay. So you could go with, was there any redness or inflammation? Anything that would suggest an infection, for example, say
Sure.
like step patches.
Yeah.
Then you could, very likely, unlikely in this gentleman, you could consider perhaps a venous thromboembolism.
Yeah.
You could.
Yeah.
You could consider an arterial occlusion, an arterial cause of pain.
Yeah.
You could consider any trauma if there's no history of such as well.
Good, that's good thought to go into. So, on exam, what are we pursuing? Sorry, I don't know your name, but we just see something. What are we thinking of on exam in particular that you want to look at? Just anything.
Okay, so a general inspection to see if there's any abnormalities to start with, and then temperature.
Yeah.
Also, you want to look at the colour, if there's any atrophic skin, or anything like that. Pulses. Just a general musculoskeletal examination to make sure it's been moved.
Yeah. Excellent. So, essentially what you are telling me, so he's general inspection, lying in his bed, he's sitting upright in quite a lot of pain. That's his blood pressure. He's got an irregular heart rate that you've noticed. Otherwise, afebrile, pretty anxiety, a bit hypertensive. His left leg's hanging on the bed and it's quite pale and appearance and cool to touch. And I thought sort of, when you look at legs in this particular situation, especially on backs, it sort of becomes quite important because it can tell you a temporal relationship as to how long has this happened, what you need to do. So, first things you usually see, it's a bit bad on the story, but the right leg is paler than the left. So if you walk into a patient who you suspect has maybe some sort of occlusion anywhere. You have a quick look and you see the leg's pale. That's pretty early on, so you're like, we possibly have time. They likely still have pulses that you can feel, or at least on Doppler. The other end of the spectrum is also pretty easy. So if you see a foot that's black, that it's probably been dead for a little while, no chances of really salvaging that foot. In the middle, it gets a little bit trickier. So you have something like this and something like this. Not the best pictures, but essentially the main difference between the two compared to this, you can sort of see it's a little bit more mottled. So, and what usually happens is in an early case, so this one will precede this one, the mottling isn't fixed. So if you press on it, it does blanch. And you often have a little central area of this cyanosis surrounded by the mottling area. That will develop and then eventually progresses to a stage where you just have mottling that's fixed. And that indicates usually a later stage, so they've sort of had poor perfusion for a long time, and then eventually that progresses. You get down to really gangrenous foot. So for argument's sake, let's say he's sort of looking like this dude here, a little bit mottled, pale. Like you said, you examine his pulses, so he's got a weak popliteal pulse, but you can't feel anything further down. You're not sure if that's because you just can't feel them or if they don't really exist. Paresthesia over the dorsum of his left foot. You do a neuro exam, he can sort of flex his ankle pretty well, but his toe flexion extension is pretty poor. Right leg though, normal sensation, normal strength, and you can feel pulses throughout. So at this stage, what are we thinking? Anybody? Or others? I'm running out of minutes.
So we're thinking arterial occlusion due to the this rule of 5 P's, so like pulseless, paresthesia, that kind of stuff. So
perfect.
Some of those present.
Exactly. So 6 P's. Thank you. Andrew actually suggested this. I'm giving credit. So the 6 P's. So pallor, pain, paresthesia, peritoneally cold, or pulseless, and paralysis. So our chap's basically got most of these features. So it's a bit concerning for acute limb ischemia, which is what we're going to go into, and something quite like. Investigations. What would you order for this chap? He's sitting in your cubicle at ED, a couple hours into the toilet. Would you order investigation? What do you think?
I'm actually not too sure.
Not too sure? Someone want to help him out? I'm just going to go sit. Yeah. Hey!
Hi. I think you probably want to do some diagnostic imaging if you could.
What would you be thinking of diagnostic?
So just thinking about an arterial occlusion.
Yeah.
Probably we wanted to do a low angiogram.
Yeah, lower angiogram.
Probably with contrast. And
Do you mean like CT or?
Probably.
Probably, yeah.
Yeah, it's like a CT angiogram.
Yeah, very fair.
It's probably a good place to go. And then I guess you could do biochemical stuff as well. So if he's going to go in for an operation to fix the ischemia, you want to do UEC,
Yep.
BP,
Perfect.
codes as well.
Perfect. Good. What other imaging can we think of? So he's sort of Tony, isn't it?
Yes.
Yeah. Sort of knocked out.
I was covering my name.
Occasionally, yeah, I remember sometimes. So he's basically knocked out a CTA, so CT angiogram, and potentially, I think he was also saying a TSA. So basically, that's your proper diagnostic angiogram. We do a catheter insertion and everything. Something else that's quite common. Really hard to get. You beg for it forever as a resident. I think James is an idea. Would you beg?
No, you go.
I don't know what it is, so you better go.
Something that's X-ray free.
Oh, just like an MRI.
You're thinking like that.
Doppler ultrasound, yeah. MRI, this guy's going to be dead by the time. Yeah. But Doppler ultrasound, really useful. And often you get Doppler ultrasound just in ED, which is enough for you to see whether, all you need to know is there a pulse down there? Is there any flow? Where the occlusion is, if you can identify it, great. Most of our patients are quite large, so it's pretty hard to see, look, it's mid-femoral unless where it's blocked. So as long as you can sort of determine there's no pulse down there, you know that there's an acute arterial occlusion, it's not something else weird that's going on. Perfect. Another thing you can sort of do is ankle brachial index. Look, realistically, you're not really going to do that on the ward. Lots of the pods do it, just for sort of completeness sake. It's basically, you just compare the pressures that you take from your brachial at sort of your arm and at the leg. If there's a difference, essentially a ratio of about less than 0.4, then you think some sort of disastrous ischemia. Normal sort of sits above 1. Okay, and an ECG, just as neat, because at the stage you're like, why has he occluded his artery? No, we don't really know. Perfect, so that's what we're going to go on to, just a brief talk about acute limb ischemia, because it's something that, sometimes we've had interns pick up on the ward and we get referrals for something else, but they instantly sort of mention that something's not quite right, so it's a good thing to be able to recognize it. So, etiology-wise, we'll just make it super simple, because that's like how I think. So essentially, you either have an emboli or you have a thrombosis of the artery. So majority of most things, as you know, embolic events tend to be cardiac in origin. AF, your most common cause, tends to affect the lower limbs more than the upper limbs, just because of the size of the vasculature, and downstream into the aorta, into your iliacs and down further is easier than going sideways, essentially into your auxiliaries, brachials, etc. Where are they most commonly lodged? Like you can imagine, any acute narrowing, so if you have a person with terrible atherosclerotic disease everywhere, they tend to lodge it where it's narrowest, where they've got a lot of plaque. Or at the bifurcation of arteries, because obviously you've got essentially a distal obstruction now, and they have to go either way. Sometimes you just sit there, so it creates a saddle kind of embolus, which can be quite disastrous. Common causes, so we've said AF, anything really that can cause any emboli. So mechanical valves, like how infarcts, where you take out your left ventricle and you have essentially poor ventricular function and just stagnant blood there. Septic emboli, they've got infected endocarditis. You can get something called paradoxical emboli. So essentially it's when you get a DVT, but unfortunately you've got a cardiac defect, so BSD, ASD, and you actually get transfer of the clot from the venous system into the arterial system, and you clot up there. Or essentially arterial emboli, which is basically, most commonly we see if you've got, say, an aortic aneurysm, you've got a sac wall where essentially you've got more turbulent flow, you can get bits of stagnant blood around the side, so you tend to form little clots, and those clots can flick off distally. It's unlikely for that to lodge in sort of big arteries like your femoral and popliteals. They tend to lodge actually really distally down in the blue toe, so you get something called a blue toe syndrome, where you just get mottling of the toes, but the rest of the foot's spared, and that's quite characteristic of this kind of emboli. Now, on the other hand, you just have a thrombosis, so a stagnant area that hasn't been flicked off from anywhere else. And a really easy way of thinking about it, either the arteries are abnormal or the arteries are normal. If the arteries are abnormal, usually due to atherosclerosis, a couple of ways it can happen. Either it progressively narrows, you just get more and more plaque forming, the blood flow decreases, it's stasis, and eventually it just thromboses that area. Or, sort of more commonly, the plaque tends to rupture, it ruptures and creates a local inflammatory effect, and that causes thrombosis as well. If your arteries are normal, then you need to explore sort of, is there a reason that they're more coagulopathic than other people? So commonly we see antiphospholipid and malignancy. Hyperhomocysteine, yeah, it's just one of those things I feel like you need to know as a med student, but we haven't really seen. And the most important thing to think about is the arterial thrombosis tends to be less severe than the emboli, because the emboli is a sudden occlusion, whereas the arterial thrombosis, usually it happens over time. The arteries in that area are already pretty crappy to begin with, so you form a lot of collaterals. So even if you knock out that big artery that's supplying the rest of the leg or arm or whatever, you've got the collaterals generally to supply the rest, so you've got time. Now, arterial trauma is another reason that you can potentially have issues with sort of acute limb ischemia. So iatrogenic, a lot of times when we go to the cath lab, they get an angio, they come out, they get a dissection or some intimal part, sort of like in this top picture, where you've essentially got flow going down the false lumen and the true lumen. Depending on how big that dissection is, that can compromise flow to the rest of the leg. Otherwise, I just thought I'd show you, this is like an IVUS, so essentially it's an intravenous ultrasound, and you can sort of see the dissection quite neatly in this one. And essentially, yeah, same thing, so blood sort of preferentially travels down there and you get reduced perfusion down. Usually we do these in people who've got terrible atherosclerotic disease anyway, so you can imagine if we partition any of the blood that they're getting down to an already sort of pretty threatened area, then it's got bigger effects than, say, in you and I. And then the true trauma, so occasionally you get, exciting stuff, so you get the transections where they come in, they've had an MDA, they've gone through with their major arteries, they're bleeding out, in which case it's quite clear cut and just patch it. Now, differences between acute and chronic. So this is one thing that gets a lot of vasculators, and if you're able to sort of nut this out, they'll be super, super impressed, because we still get referrals from registrars who sort of tell us the same thing, but it's actually a completely different thing. So chronic limb ischemia, in comparison to acute, like its name suggests, it's been going on for a longer time, you get collateral vessels. So we won't jump out of bed and 2 in the morning you tell us someone's coming and they've been progressively getting worse, but it hasn't really developed acutely or anything like that. We know there's a past history of bad peripheral vascular disease. Acute, usually rapid decline. There may be, in some individuals, there's sort of weird picture where you know they've got that disease, but something they've gone down really quickly. In that case, it might be that in that particular area, they unfortunately just don't have collaterals. And so they basically act like an acute limb ischemia. Now, in our chat, I was just wondering, do we think it's a chronic cause or a more acute case? And what sort of findings support that?
It's probably more acute.
More acute? What do you think about?
Because of the sudden onset of pain, the longer that pain in the past. And then he's got like quite a few of the P's as well.
Yeah.
And you think perhaps it was a chronic cause with an acute obstruction, you might not get so many of this and still some collateral supply.
Perfect. Yeah. Was that?
Yeah. Word for word, really.
Great minds think alike. Good. And the other thing that you can notice is on his right side, he's got completely normal pulses. So if you think that, this guy's actually got pretty bad peripheral vascular disease, very unlikely you'll get such a good complement of pulses on the other side when one side's taken out. So that's quite a common way that we sort of see. Cool. Now, what about critical limb ischemia? So this term gets thrown about a lot. We get referred a lot of this from ED. Like from its name, it sounds pretty bad, like an acute limb ischemia because it's critical limb ischemia. So what's the difference between, say, acute limb ischemia and this?
My understanding, critical limb ischemia is a complication of the chronic disease, chronic arterial disease. There's a particular ankle brachial index that defines it from memory, maybe 0.8. I'm not sure. And it's just an indication of the severity of that chronic disease. It's not acute.
Yeah. Excellent. So that's the most important thing. Critical limb ischemia, acute limb ischemia, totally different kettle of fish. So critical limb ischemia, essentially, like Naz was saying, it's very severe peripheral vascular disease, and it's characterized by these two things, really: breast pain and tissue loss. So whether that's an ulcer or they've got frank gangrene, the difference between that and just your normal run-of-the-mill peripheral vascular disease is that usually you get people come in and they're like, oh, I've got bad intermittent claudication, I can walk about 50 meters. People with critical limb ischemia won't tell you that. They'll be like, the thing that bothers me the most is at night when I sleep and I raise my legs, I get pain in my calves all the way down to my feet. And they'll get very often sort of ulcers over their heels and sort of distally into their foot. If you have these kinds of features, and that's what we call critical limb ischemia, implications-wise, not really a whole lot other than you try to expedite, their treatment. It's just something that you'll get asked a lot about by the vascular people and by EDs who sort of refer for this critical limb ischemia kind of thing when it's actually acute. It's just an important distinction because we won't run in for this, but we'll run in for the acute limb ischemia. Now, grading up to severity, because this is sort of where it becomes important if you know a bit more, because then basically if you know how severe it is, you know what management we're going to do, and that makes it super easy for anyone sort of taking on the patient. So simple again, a limb's either viable, non-viable, or somewhere in the middle, it's threatened. And I find a really useful way of looking at this, essentially, is this thing called the Rutherford scale. So he's like basically the god of vascular surgery. And he's come up with this scale, which essentially dictates management as well. So really simply, first stage, the limb's viable, doesn't look like it's immediately threatened. No neurological signs, so station, strength are both intact, and you've got pulses. The second stage is when the limb's threatened, and that's split into A and B. So A is sort of basically like, it's a little bit threatened, but not too worried about it. You're starting to get some sensory loss, usually very distal in the toes, no weakness yet. And then this is when your pulses start to go, so you can't really quite feel them, but you can sort of hear them occasionally on a Doppler. 2B is when you're sort of worried, you see this plague and you want to take it straight to theatre, because if you leave it any longer, it will probably progress to stage 3. So numbness has sort of spread more than the toes. might be, and the fourth might be up the leg. You have associated weakness in the area, and you can't feel any of the pulses. You can't really hear them on the Doppler either. And then 3 is often really clear cut. It's irreversible ischemia already. There's nothing you can do, even if you take them to theatre right now, to fix that. They often have really dense sensory loss, can't feel a thing, they can't move their foot, and you can't hear anything even on Doppler. And that sort of guides management, because essentially, if you're 1, you have time for a workup. You have time for an ultrasound, you have time for a CTA. If you're going in the 2A and 2B, we often don't bother. Unless you can sort of get one en route to theatre, there's not much time, and there's not much point because often they'll have to go to theatre anyway. And 3 is you just have to proceed to amputation. There's nothing in the way of sort of revascularization things that you can do for it. All right, so for our chap, what do we think he's at? Which sort of stage? What severity? That's just for symptoms. Yeah, exactly, 2B. So he's got more than twice his whole foot's numb. He's got weakness and he's got 4 pulses. Excellent. Now, so we call that a threatened limb. What do we do for management-wise? Generally, for anything with acute limb ischemia, you just avoid any delay to revascularization if you can. Depending on how acute it is and how the general patient is, you know, for any tissue, 4 to 6 hours is usually a time window to try and save it. Anticoagulation, unless they've got a contraindication, sort of like a vascular bleed, recent surgery, intracranial bleeds, things like that, then you sort of think about it. But most of the time you give them a heparin bolus and you start them on an infusion straight away. This essentially, it doesn't obviously dissolve the clot, but what it does is stops it from propagating more distally. So then if you were to intervene either endovascularly or open it in theatre, you don't have to go sort of all the way down the leg trying to fish out clot. Yeah, those are sort of the 2 main points. So in this particular situation, so grade 2, you're really looking at a surgical vascularization. I know there's sort of endovascular stuff where they go in and they do fancy things with stents and balloons and stuff. It's sort of the new rage, but it's it often takes too long. And one of the things that we do endovascularly is just thrombolysis. So you essentially put a little catheter down right next to the clot and you squirt a lot of streptokinase, dissolve the clot, and all is well. The tricky thing with that is that you usually take so long. So you squirt it and then it sort of breaks up a little bit, and you squirt some more and it breaks up a little bit. So if you're at the stage where you only have maybe an hour, a couple of hours before you can actually save it, and tissues are dying, it's looking a little bad. If you go straight to theatre, what you do is usually an embolectomy. So like it's saying, you make a little nick in the artery that's affected. You pass basically a Foley catheter all the way down past the occlusion, inflate it, and yank it back up, and basically just yank the clot out. Pretty effective, pretty simple. The only thing that complicated is some people sometimes have an occlusion because they've got aneurysms, and if you've got an occlusion because your aneurysm's clotted, most commonly in the popliteal area, that's pretty bad because the only way you can fix you can't embolectomy sort of aneurysmal occlusions, because if you do that, you've got a high risk of rupture, and you've totally just messed up that area of the artery anyway. So in those cases, you have to go to a bypass straight away. And often people who have popliteal sort of aneurysmal disease aren't great candidates for bypass surgery. So a lot of times tend to be sort of your smokers with cabbages in the past. So all their great stats have been taken. Just doesn't let you do anything. So in those situations, it becomes tricky, and amputation becomes a much bigger possibility. It's just, yeah, it's a sad fact, but it happens. But in the rest of the population, embolectomy is pretty good, nice, quick, and effective. And often you do your completion angiogram, like you're saying, at the same time, just to make sure everything looks beautiful. If you've got little bits here and there, you might squirt at them with a bit of thrombolytic agents. And if it's been sort of going on for a little while, you might consider fasciotomy at that stage because you're concerned that they might develop compartment syndrome. Now, what if we had this? What stage do we think he's at?
Stage 1.
Perfect, stage 1. Excellent. So he's got a viable limb. We're not as worried. Same thing with anything that you think you can say, start the anticoagulation unless there's contraindications. This is where there's time for your imaging. There's time for your ultrasound, the CT angiogram, maybe a diagnostic angio if you want to. And this is where the intra-arterial thrombolysis, so just via a little catheter, becomes a much more prominent role because you've got time. You can wait for the clot to dissolve and see how things go. A lot of these do eventually need surgery anyway. You don't clear the whole clot or something else happens. But it does make the magnitude of the surgery you need to conduct a lot less because obviously you thrombolyze a lot of the clots, so it's only tiny bits. So it tends to be quicker and you don't have to be as extensive in terms of clot retrieving. The decision of whether or not it is suitable for this sort of endovascular thrombolysis depends on sort of those factors there. So the length of the occlusion, if the occlusion is super long, you've got it all the way down your superficial femoral artery, you're probably not going to thrombolyze the whole thing because you're going to end up getting a lot of the thrombolytic agent sort of intravascularly, which has sort of increased rates of intracranial bleeds, GI bleeds. The location of the occlusion, if it's all the way down your foot and your puncture starts in the groin, it's going to be a real pain getting all the way down if you're going to essentially operate. Whereas if you have just a little catheter, you can just pass it all the way down and the non-occluded bits and squirt it. If you operate, you kind of have to make long incisions all the way down to make sure that there's no more proximal sort of occlusion. So ideally, in this situation, you probably go with the intra-arterial thrombolysis. Length of ischemia, sort of like we were saying before, if you had a longer ischemic time, you want to go to the theatre fast because often that gets things done quicker. And overall patient health, is the patient even suitable for surgery? Is there a bypass conduit? Can they actually tolerate it? This all sort of has to be taken into account. And this last one, what if you had this? Great, yeah, so what do you do in this case? Yeah, so you amputate. That's basically all you have to do. You've got non-viable tissue. Keeping it there longer, it just increases risk of rhabdo, increases risk of renal injury, infection. Clinical assessment sort of guides the level of the amputation, so you don't really need much imaging because you know it's dead. And as much as you can, you try to go as distal as you can and leave as many joints as you can. So there's a big difference in terms of patient satisfaction, morbidity, mortality between below the amp and an above the amp. Because below the amps, you've got the knee joint, you've actually got control, flexion and extension at the knee. Above, obviously, you don't, you're sort of moving it from your hip down. So with the knee prosthetics, it probably is a lot better than it was before. The imaging might not be necessary initially, so they're really gangrenous and you're worried that they might go into septic shock. If you're deep in the theatre, you can amputate. The issue afterwards is a lot of these people actually have occult peripheral vascular disease, which is poor disease in general. And a lot of times, even if you amputated the stump doesn't heal because they've just got poor perfusion, in which case you might take them to theatre or to radiology, interventional radiology, and put stents or angioplasties to try and improve the blood flow to just that area of the stump to try and get it to heal. Because often sort of we think about, oh, we amputate and that's it, but until they've healed and they can fit the prosthesis, they can walk around and ambulate like that, their job's not really quite done. So that's when imaging might be necessary just for future revas. And in addition to all this, holistic patient care, a lot of the patients, particularly the younger ones, and they're not prepared at losing their limbs, post-trauma and things like that, psychological support becomes really important. Offering them orthotics, getting orthotics to see them often and early, often gets them feeling a bit better in terms of being able to return to functional work and things like that. Excellent. So take-home messages. Essentially, really simple. It's a simple topic. All you have to do, you just recognize it. If you have any concerns, I wouldn't say no. Most vascular surgeons and most medical surgeons won't be angry if you call them with concerns about acute limb ischemia because it's high stakes. All the patients you think has a limb that's salvageable, you anticoagulate unless they can't or they've got contraindications. So that's with heparin, bolus, and then heparin infusion. Assess the severity and they'll help you guide their management as well, whether or not they're suitable for further imaging or whether or not they just go straight to theatre. And that's it.
Do you have any questions?
Yeah.
You do, this might be a really dumb question.
No.
You do endarterectomies with peripheral vascular disease. the way that you'd be doing the carotid intervention.
Yeah, so you can do that. So that tends to be more proximal. So usually is if you've got SFA disease, so superficial femoral artery disease, that's when you do it. If it gets further down, it's not impossible. So you can do it for popliteal and bigger vessels as well. But you're getting to sort of the posterior tibial, anterior tibial, that gets a bit tricky. Just because to access them, firstly, you have to cut through a lot of structures and particularly the nervous structures. And just the vessel size is so small, often as you're trying to sort of endarterectomy them, you can cause quite a bit of damage to the surrounding sort of intima and things like that. Yeah. Okay.
Thanks for the talk.
That's right.
In terms of who does the surgery,
Yeah.
typically the endovascular stuff, is that radiologists or is it
It's a very contentious point. Here, yeah, there's grumbling sort of disagreements between the two people here. A lot of times the referral will be made to us because you can't sort of acutely refer as easily to interventional radiology. If it's thrombolysis and we don't think they need sort of acute, any other surgery in addition to that, they often go to interventional radiology. But now that there's a hybrid suite, it means that we can sort of do both. So we can do the endovascular thrombolytic treatment. If that doesn't work, then we can open them up at the same time. So I would say that, but I'm biased. So, yeah.
When you say that the level of amputation is based on a clinical assessment,
Yeah.
is there ever a grey zone where you'll delay primary closure and go for a vac dressing to wait for stuff to present, or will you more often than not aim for primary closure?
No, absolutely. A lot of our cases where they're presented really late, they've got a really necrotic leg, and as we go and amputate, so the muscles, particularly if we're concerned that of the viability of any of the remaining muscles, vac is an awesome way to do it. You go back, 3 or 4 years later to change the vac, see if the muscles are viable. If it is, excellent, think about closure. A lot of the times for these patients, they have diabetes, they often don't take very good care of themselves, and they often have quite infected wounds. If there's any chance of infection, we know that they've already got a poor chance of healing the stump. Anything that can potentially threaten that, we want to minimize, so that goes on a lot of the time. Yeah, that's a good point. And then they might need flats, in which case we have to you guys. Yeah. Yeah.
Is a bedside ultrasound a diagnostic study for arterial ischemia?
Depends who does it. So if it's sort of your senior vascular registrar, he's probably quite comfortable to make a call. Most of what we do sort of at our level would be you just get the Doppler and you see whether, like, you can't feel the pulses. Half the time you don't know if you're actually feeling correctly or if you're feeling your own pulse. And I can feel that. So you get the Doppler and you just listen, because if the Doppler can't pick it up and you're sort of, pretty sure you're in the right spot, then that generally does prove that there isn't any perfusion down there, and it sort of adds an extra level, because you say to a reg, I can't really feel them, whatever. But if you say I can't hear them with Doppler, then they know it's firstly you know what you're talking about, and secondly, even on a more sensitive way of measuring it, you can't feel it.
Yeah.
If you sort of become sort of more proficient with ultrasound, you can always just see almost on a color Doppler, see whether or not there's any flow. Tricky thing is, I think even for even junior registrars and things like that, it's tricky to position the patient in such a way if they've got really sort of bad pain that you can be quite confident saying there's no flow here.
Yeah.
So I reckon if you've got time, just a Doppler by the bedside is probably your highest yield.
Do you think it's the kind of thing that won't necessarily replace a CT angiogram because you always have time to organise one? Like,
I think
you're talking about it's kind of those grade 2 people.
Yeah.
About like kind of hours almost.
Yeah, so I guess with the CT, the good thing about the CT compared to the ultrasound is obviously it gives you anatomical details, so you know when you're going in, oh look, there's a structure here, I can avoid it.
Yeah.
But the bad thing I think is most of our patients also have diabetes, they have shocking kidneys.
Yeah.
Majority of these people that we see who come in, unless they're like young and fit post-trauma, that's fine. Often they get a CTA, they diagnose that area, that's fine. But most of the crumbly ones, they actually don't have enough renal function for a CT, especially if we're going to go to theatre and then we're going to do an angio and they get more contrast then.
Yeah.
So it's a matter of prioritizing, we're going to probably give quite a big insult to their kidneys at some stage. Do we say before or after we think we've done the job, or before? And usually it's safe for after.
Yeah. Cool.
For fibrinolytic therapy, do we still use streptokinase in this centre, or are we looking at like
Urokinase.
retaplase and alteplase stuff?
I think it varies from what I saw, because I recently did this audit thing. We use The two most common are streptokinase and urokinase for our centre that we see in interventional radiology. I don't know what the current movement is away. When I looked at it, it was sort of relatively even split, like 60-40 roughly, and then some other ones they just listed as TPA, so we don't know what they used.
Is that a cost thing or?
I don't know, but I want to say yes. I feel like it probably is driven by cost. I don't know if there's a big difference between the two, all these agents. Yeah.
Hey, so if someone has an EGFR5 and is waiting for a renal transplant,
Yep.
and would they still be eligible for endovascular?
When you say they're waiting for renal transplant, are they on dialysis? Because then anything's possible. Okay, maybe they just get dialysis, that's fine. But if they're not, if they are
Waiting for a renal transplant.
it sort of does vary. Most of the time,
Do you still go to them to theatre or
Yeah.
palliate?
well, I don't know. I think as surgeons, you generally hold on to patients as much as you can, and then once things all go to shit, then you're like, oh yeah. But I would be hesitant to say. I mean, look, realistically, the mortality for acute limb ischemia, sometimes there's studies that say in hospital mortality is under 20%, and 1 year mortality is 20%. So it's a lot of the times a sort of terminal event for most people. If you've got a really crumbly person who's, if the only thing they've got is end-stage renal failure, they've got no other comorbidities, they're like, anesthetics-wise, they're excellent, and they're probably better than a lot of the other patients we operate on. So that would get intervention, and you just write the consequences. If they, weren't previously being dialyzed, they just get dialysis after, especially if they're going to get it on the transplant list. If they're overall really crumbly and they're anesthetically at risk, then it just becomes a discussion with the patient and the family what they want to do. Yeah.
In the cases where this is a terminal event,
Yeah.
what do the patients usually die, like sepsis or?
Usually sepsis. So 4 to 6 hours, the tissues get ischemic, so the next day, they just essentially get more and more like that foot, and then just gets infected and they get septic shock. Yeah.
Are there any complications for them after you've taken care of it?
After we fixed it, depending on what you do. So if it's just an embolectomy and you sort of put a little patch on the top, then most of the time it's fine. Acute complications you can get patch blowout. So the bit where you make the hole and you put a patch on, that unfortunately somehow just ruptures, in which case it's a surgical emergency because you can imagine you essentially have a hole in the artery. Other than that, sort of further down the track, it just implications-wise, not so much from the surgery, but it's sort of, if you've had acute limb ischemia and you've had some sort of thromboembolic event, then you're more likely to have it in the future. So it's just, we don't know why, it's just a matter of investigating and trying to reduce that risk, especially if you've got a known cardiac cause like this guy probably did, then you can try and fix that. But from the surgery itself, other than sort of the acute, your usual infection, bleeding, that kind of stuff, not really. Yeah.
Is there like a code for acute limb ischemia, like code stroke or?
No, sadly, no. That would be so awesome. No, but that's actually a good idea. We should have that. No, there isn't. But if you call any anesthetics consultant and you're like, I've got a chat with acute limb ischemia, I guarantee you'll get the next one.
Yes.
Unless it's a brain, in which case it's not.
Thank you.
How often do you use stenting at the same time?
As this, if the reason is more a thrombotic kind of reason, then that will be part of your management. If it's an embolic one, not usually.
Right.
Awesome.
Thanks everyone for